Hello dear friends, today we are talking about main renal syndromes. Content of our lecture includes 9 renal syndromes. They are urinary syndrome, edematous syndrome, nephrotic syndromes, arterial hypertension. Also we talk about acute and chronic renal failures, dysuria syndrome and pain syndrome. Let's talk one by one, and let's start from urinary syndrome. Is a complex of changes in the physical, chemical properties and microscopic characteristic of urine sediment in pathological condition, and includes proteinuria, hematuria, leukocyturia, cylindurias. This syndrome may be accompanied by clinical symptoms of kidney disease or exist in isolation without any other renal symptomatology. Presence of urinary syndrome is always the most important proof of kidney damage. Includes proteinuria. Proteinuria is the excretion of protein in the urine in excess of normal values. Normally, no more than 50 milligrams of protein, consisting of different plasma low molecular weight proteins, is excreted in the urine per day. There are two types of proteinuria according to origination, functional and pathological. Of course, pathological proteinuria appear only in pathological condition or in kidney or urinary tract disorders, whereas functional may be present even in normal condition and includes the different types. For example, orthostatic, occurs in young people and does not exceed 1 gram per day, disappears in the supine position. Feverish, which may occur only during fever. Proteinuria of tension, it occurs after severe physical exertion and disappears during normal physical exertion. Proteinuria in obesity, or also may appear physiological proteinuria during pregnancy, or proteins may appear in urine without any causes, like idiopathic transient proteinuria. Proteinuria by source. There are 3 types: prerenal, renal and postrenal. Prerenal or proteinuria overflow observed in multiple myeloma, for example, in microglobulinemias and massive intravascular hemolysis, when appear large amount of proteins with high mass. These proteinuria are not a sign of nephrotic, and don't have signs of nephrotic syndrome, since it's not accompanied by hypoalbuminemia and other signs. Renal glomerular and tubular proteinuria. There are 2 types. Glomerular proteinuria is observed in most kidney diseases which cause violation of glomerulus, glomerulonephritis, renal amyloidosis, diabetic glomerulosclerosis, whereas tubular proteinuria is observed in any disorders which characterized by damaging of tubes and institutional tissues. Postrenal has an extrarenal origin, develops in the presence of a bacterial inflammatory process in the urinary system. For example, pyelonephritis due to an increase in excretion of plasma proteins into the urine. By composition, we detect 2 types, selective and non-selective proteinuria. Selective proteinuria characterized by the release of a low molecular weight protein, mainly albumin, and non-selective proteinuria characterized by appearing not only albumins, also characterized by appearing high molecular weight proteins as globulins. By degree of expression, we distinguish 3 types: microalbuminuria, excretion of albumins from 15 to 500 milligrams per day, and character mostly for diabetic nephropathy or kidney damage with arterial hypertension, and etc. Low and moderate up to 1 gram to 3 grams per day, character for glomerulonephritis, pyelonephritis, or any kidney tumors, and high or nephrotic more than 3 to 3.5 grams per day. Next is hematuria, is the presence of blood in urine, and as you see here in graph represented urine analysis of 3 glass test, and for example if initiation of hematuria in first glass mostly suggests a urethral source, where when you see hematuria in all glasses suggests a bladder or a renal origin hematuria, and hematuria of in terminal glasses or in the last glass suggests a prostate source or maybe a bladder neck violation. There are also types of hematuria because of origin. For example, extrarenal causes of hematuria, there are any stones of ureter, bladder, tumors of urinary tract, any infections, and using some medicines like cyclophosphamide or heparin or warfarin, and any traumas of urinary tract. Renal globular hematuриas develop because of primary renal glomerular lesions and secondary lesions for systemic disease, character for systemic diseases, and hereditary family syndromes like Alport syndrome or Fabry diseases. Renal non-glomerular hematuриas develop because of primary renal glomerular lesions, for example, renal cell carcinoma, or vascular damaging of kidney infarction, renal vein thrombosis, any metabolic changes, renal papillary necrosis, and using of some medicines, and cystic kidney diseases. According to degree of hematuria, we distinguish three types: macrohematuria or severe hematuria, when urine of the color of meat slope, more than 50 erythrocytes in the field of view; moderate, when 30 to 50 RBCs in field of view; and insignificant, up to 30 RBCs in the field of view. According to duration of hematuria, we distinguish short-term, intermittent, and resistant hematuria. Next is cylindruria, also part of urinary syndrome, appearing of CAS in urine. CAS are proteins or cellular formation of tubular origin, having a cylindrical shape and different sizes. There are different types of CAS, and these CAS content give us information about any disorders. For example, hyaline CAS may be present 1 to 2 in normal condition, whereas granular CAS and waxy cylinders, fibrinose, epithelial CAS, or CAS from erythrocytes give us may appear in very severe renal disorders. For example, CAS from leukocytes may appear during inflammation, like pyelonephritis or in lupus nephritis. Leukocyturia, also part of urinary syndrome. Leukocyturia, an increase in leukocytes in urine, normally for men character 0 to 3 in the field of vision, for women less than 5 in field of vision. An increasing content of leukocytes is observed in inflammatory processes of kidney. Sometimes in transient leukocyturia occurs may in fever. Renal origin of leukocyturia is evidenced by total leukocyturia with the simultaneous presence of leukocytes and granular CAS in urinary sediment. Also, you should know concept as a pyuria. Pyuria is when urine become to be purulent and we have much large content of leukocytes, more than 10 to 4 degree. And also you should know there may be active leukocytes which may character for inflammation of urinary tract, or for example cystitis, urethritis, and prostatitis. According to classification, leukocyturia may be true or false. False, for example, neutrophil may be because of any genital origin or impaired urine collection. Also true leukocyturia, we have two types, bacterial and bacterial. In a bacterial type will be seen only lymphocytes and eosinophils, which may be appear in viral nephritis, in medical nephritis or lupus nephritis, whereas bacterial origin of leukocyturia may represent as pyelonephritis, cystitis, and urethritis. Next is epitheliouria, also part of urinary syndrome. Squamous epithelial cells indicates a desquamation of epithelial cover of the lower urinary tract, for example, bladder and urethra. Cells of the columnar epithelium are cells of epithelium lining of renal, pelvis, or ureter. The appearance in the urinary sediment indicates an inflammatory process in the pelvis, pyelitis or ureter. Simultaneous detection of cells of columnar and squamous epithelium may indicate an ascending urinary tract infection. Renal tubular epithelial cells predominate in urine sediment when tubular necrosis, chronic glomerulonephritis, lupus nephritis, amyloidosis, and etc. Next is syndrome of dysuric disorders. Dysuria, disorders of urination. Normally, daily amount of excreted urine or diuresis averages from 50 to 80 of fluid drunken, ranges from 1 to 2 liters. And we distinguish two types, positive and negative diuresis. Positive diuresis, a patient excretes more urine than drinks. It may happen during the taking diuretics or in polyuric stage of acute renal failure. Negative diuresis, when patient excretes urine significantly less than fluid intake. Observed with water retention in body or with increased excretion of it by the lungs and skin, for example, with hyperthermia or a heating condition. Manifestations of dysuria, they are oliguria, when urine less than 500 milliliters, anuria less than 50 milliliters, polyuria more than 2 liters, nocturia, nocturnal diuresis more than 1/3, polycurious, frequent urination more than 7 times a day, and strenuria, painful urination. Next is pain syndrome. Renal tissue does not have pain sensitivity. The appearance of pain may occur due to stretching of capsule or pelvis as a result of inflammatory disorders. For example, stretching of capsules may occur due to edema of renal tissue or kidney edema, or this pain may occur during passing of stone through the ureter. Peda or edematous syndrome, edema as a result of renal dysfunction, can affect all parts of body. It's often initially manifest in tissue with loose connective tissue matrix, such as eyelid, periorbital edema, as thus a characteristic finding in severe renal disease. And unlike cardiac edema, renal edema characterized by formation from the upper body part and goes into the lower part. Pathogenesis, origination of edema syndrome, connected with different mechanisms. First mechanism, increasing the permeability of capillary wall. Next is decrease in oncotic pressure of blood plasma due to hypoproteinemia, for example, in nephrotic syndrome. And natremic edema caused by delay in blood and tissue of sodium ion. Sodium ion are highly hydrophilic, and with an excess of the body, edema occurs due to excessive release into the blood of adrenal cortex hormone aldosterone and due to activation of antidiuretic hormone. Edema can occur with an acute cessation or sharp decrease in formation of urine, for example, in anuria or oligonuria condition in acute or chronic kidney failure. Next is nephritic syndrome, is a set of clinical symptoms that create a clinic of acute nephritis characterized by classical signs like hematuria, blood in urine, this urine color as mid-slope Next is swelling of limbs and face, macrohematuria, arterial hypertension, hypocomplementemia, and oligonuria. In most cases of impetus for the development of syndrome is an infectious process caused by activity of pathogenic bacteria and viruses. Nephritic syndrome mostly represents of acute glomerulonephritis. And we have several factors which provoke the development of acute nephritic syndrome. So various kidney diseases, systemic diseases, viral disease, and bacterial infections like pharyngitis. Complications of nephritic syndrome are cerebral syndrome like headache, nausea, vomiting, decreased vision, mental irritability, acute left ventricular failure till pulmonary edema, acute renal failure. And there are some disorders which are accompanied by nephritic syndrome like acute post-streptococcal nephritis, acute tubular intestinal nephritis, exacerbation of chronic glomerulonephritis, and kidney damage and systemic connective tissue disorders. Next is nephrotic syndrome. This is collective concept that includes the following clinical and laboratory symptoms like massive proteinuria more than 3.5 or 3 grams per day, violation of protein metabolism, hypoproteinemia, dysproteinemias. We have a difference, violation of the relation albumin and globulins, hyperlipidemias when increased cholesterol level and increased beta lipoproteins, and nephrotic edemas. In nephrotic syndrome, you see as in picture, in nephrotic syndrome we have mostly podocyte damaging, which increase the permeability of glomerulus. In nephritic syndrome, we have disturbances, inflammation disrupting glomerular basement membrane. You see basement membrane damaging, whereas in nephrotic syndrome, for nephrotic syndrome, character podocyte damaging. Nephrotic syndrome pathogenesis at the heart of the nephrotic syndrome is the immune mechanism. Immune complexes increase the permeability of basement membrane and the structure of podocytes, the absorption of proteins in the urine increase, loss of albumins and globulins, which give us massive proteinuria, and it's a result of massive proteinuria developed hypoproteinemia and hypoalbuminemias, and cause the hyperlipidemia and hypercholesterolemias. And due to decrease in cardiac pressure and activation of renin, angiotensin, and aldosterone system of blood, appear massive edemas. Next syndrome is arterial hypertension syndrome. Includes a number of symptoms arising and increasing BP more than 140 to 90, may represent of kidney diseases and renal arteries. And according to mechanisms, we distinguish two types: renovascular and parenchymatous. Parenchymatous arterial hypertension connected with the decreasing level of prostaglandin synthesis, whereas renovascular, there's most recognizable mechanisms. Renovascular characterized by increasing in damaging of renal artery or decreasing pressure in renal artery, cause the renin activation. Renin increase number of angiotensin 1, which under action of angiotensin converting enzymes change into the angiotensin converted into angiotensin 2 enzyme. And angiotensin 2 is very strong vasopressor, which cause vasoconstriction and increase peripheral resistance. And also another action is activation of thirsty center and increase aldosterone production by adrenal gland. Aldosterone cause water retention and sodium retention and increase also blood volume. Increasing blood volume in one hand, and in another hand vasoconstriction cause increasing peripheral resistance and amount of blood and cause elevation of blood pressure. In case of parenchymatose, we have decrease prostaglandin production, increase suppressors and activation of renin-angiotensin aldosterone system.